Okay, good evening, everyone. Sorry for the delay. We're going to be looking at something very important to us as anesthetist and critical care practitioner. Look at oxygen transport and therapy. All right, so this will be our linear comps. We won't have time to go over that, and this is our outline. So oxygen transport is a complex process by which oxygen from the atmosphere, all right, move into the body and is transported to the different tissues where it is used for cellular respiration and energy production. So all the processes through which oxygen is moved from the external environment to the body is what we know as oxygen transport. And there are about 4 elements that are involved in oxygen transport, which includes ventilation, diffusion, circulation, and cellular utilization. All right, one of the first things we need to remind ourselves regarding oxygen transport is this, what we call oxygen cascade. All right, this refers to the various steps in the concentration gradient for oxygen as it moves from the atmosphere to the mitochondrial level. All right, and this is governed by the Darting law of partial pressure, as we're going to see later on. The partial pressure of oxygen in the atmosphere is about 159, all right, because it contains about 20% of total air. All right, as it gets into the upper airway, this gets reduced because of the partial pressure of vapor pressure of water, which is about 47. All right, as it goes into the alveoli, it gets reduced further to 100 millimeters of mercury. This is due to uptake of oxygen by the pulmonary circulation. At the arterial blood, due to venous admixture, this partial pressure gets reduced further to 97 millimeters of mercury. At the mid-capillary blood, it's about 50 millimeters of mercury, and at the mitochondrial level is between 4 to 20. These differences in concentration gradient allows for diffusion of oxygen from the atmosphere down to the mitochondrial level. All right, so this is just a pictorial diagram to show us how this happens from the atmosphere. This is the partial pressure of oxygen is 160 as it goes down. So this allows for ease of diffusion of oxygen from the atmosphere down to the mitochondrial level. All right, and this aids oxygen transport. Now, it's important for us to talk about alveolar gas equation because this is what is used to calculate the partial pressure of oxygen at the alveoli. All right, so this is represented as we can see, and as we go on, we also see how important this is when we're calculating our AA gradients. So the partial pressure of oxygen at the alveoli is equal to the FiO2, all right, which is equal to the multiplied by the atmospheric pressure and the vapor pressure like we saw, divided by the partial pressure of carbon dioxide minus the partial pressure of carbon dioxide divided by the respiratory quotient, which is 0.8 at rest. Now, oxygen carrying capacity of the blood is determined by 3 very important factors: hemoglobin concentration, the oxygen saturation, and the amount of oxygen that is dissolved in plasma, which makes up the partial pressure of oxygen. Well, we're going to see this more because of our time, all right? There are different forms of oxygen in blood. We have the small one that is dissolved in plasma and the larger portion that is combined with hemoglobin, all right? Only about 0.3 ml of oxygen is dissolved in 100 ml of blood at a partial pressure of oxygen of 100 millimeters of mercury. And the amount of oxygen that is dissolved in plasma or in blood is governed by Henry's law, all right, which states that the concentration of any gas in solution is proportional to its partial pressure. So the higher the partial pressure of oxygen of the arterial partial pressure of oxygen, the more oxygen is dissolved in plasma. And as little as this is the oxygen dissolved in plasma that actually represents the partial pressure of oxygen in blood. So more importantly is the oxygen that is combined with hemoglobin, all right? And we do know that hemoglobin increases or enhances the oxygen carrying capacity of blood by almost 30 to 100 folds, all right? Oxygen combines with hemoglobin in 4 different steps. We're going to see that as we go on. When hemoglobin is fully saturated with oxygen, 1 gram of hemoglobin will contain about 1.39 ml of oxygen. So if you look at an average hemoglobin concentration of 15 grams per DL, 100 ml of blood will contain about 20.1 ml of oxygen. All right, there's this concept of comparative binding that is interesting. All right, each molecule of hemoglobin can hold about 4 oxygen molecules. All right, don't forget that we remind ourselves that hemoglobin is a tetramer, all right, made up of 4 protein subunits. All right, so the combination of oxygen with hemoglobin causes a change in the shape of the hemoglobin. All right, so the change in shape of hemoglobin also leads to a change in affinity of hemoglobin for oxygen. So the more oxygen is bound to the hemoglobin, the higher the affinity of hemoglobin for oxygen. So this is called cooperative binding. So the first oxygen binds to hemoglobin makes the subsequent binding of hemoglobin with oxygen faster, all right, because there's increased affinity of hemoglobin for oxygen. Now, when no oxygen is bound to hemoglobin, the molecule is said to be in a test state, and this has a very low affinity for oxygen. But when the first oxygen molecule binds to it, the hemoglobin changes shape into what we call the arrow state, the relaxed state, which has a higher affinity for oxygen. All right, so these are definitions we'll come across as we go on because of our time. All right, now let's go to oxygen dissociation curve. This oxygen dissociation curve depicts the relationship between the percentage oxygen saturation of hemoglobin, known as SpO2, and the partial pressure of oxygen. Now, if you look at the oxygen dissociation curve, it has some unique features. Number one, that is a sigmoid curve. All right, the upper part of the curve is relatively flat and has clinical significance, which means that a higher PO2, all right, will not, no matter how high you want to increase the PO2, the SpO2 will not increase significantly. So if you get it from maybe a PO2 of 70, all right, SpO2 remains around 94, 95. So the higher, doesn't matter how much oxygen is dissolved in plasma, you're not going to be able to raise the SpO2 more. And if you look at this other steep side, a small increase in PO2 of oxygen leads to an elevated increase in SpO2. So this is why it's very important for us to appreciate this sigmoid curve of the oxygen dissociation curve. A very important step here is the partial pressure of oxygen at which hemoglobin is 50% saturated with oxygen. All right, so this is usually given at 27%. At 27 millimeters of mercury of oxygen, hemoglobin is about half, all right, saturated with oxygen. And this also goes to show you that an increase in PaO2, all right, from this point, an increase in PaO2 does not lead to an exaggerated increase in SpO2. All right, another very important thing about the oxygen dissociation curve is that there's under certain circumstances, this green curve can either shift to the left or to the right. And a shift to the right and a shift to the right has significant effect, all right? A shift of oxygen hemoglobin Oxygen dissociation curve to the left means that there is higher affinity of hemoglobin for oxygen. So hemoglobin binds slightly more to oxygen, while a shift to the right means a lower affinity of hemoglobin for oxygen, and this leads to unloading, all right, of oxygen to the peripheral tissues. And there are certain conditions under which you have rightward shift of your oxygen dissociation curve. All right, things like a rise in hydrogen concentration, a fall in pH, there's acidosis, a rise in PCO2, increase in D3 diphosphoglycerate levels, and a rise in temperature. All this will cause a rightward shift of your oxygen dissociation curve, and that leads to lesser affinity of hemoglobin for oxygen, and that makes oxygen available to the tissues. The converse is true when you have a leftward shift, like I mentioned. All right, you have higher affinity of hemoglobin, so hemoglobin binds more tightly to oxygen, and so we have a fall in hydrogen concentration, alkalosis, a fall in PCO2, a decrease in D3, D2,3-DPG, all will cause a leftward shift of your oxygen dissociation curve. All right. So let's look at some of the factors that we mentioned before. There are certain effects, the Bohr effect and the Hardin effect. These are important effects that has effect on the position of the oxygen dissociation curve. All right. The Bohr effect, when there's an increase in PaCO2 or a decrease in blood pH or in acidosis, this leads to a lower affinity of hemoglobin for oxygen. So a Bohr effect will cause a rightward shift to your oxygen dissociation curve, and that causes enhanced unloading of oxygen by hemoglobin to the tissues. All right, there's what we call the double Bohr effect, and this applies in pregnancy where carbon dioxide diffuses out from the fetal circulation to maternal blood. So what happens is that there's an increase in maternal CO2 and a drop in fetal CO2. So that means that in the maternal blood, there's lesser affinity of hemoglobin for oxygen, and that favors oxygen transfer from the maternal blood to the fetal blood. So this is what we call the double Bohr effect. The Hardin effect is a reciprocal of the Bohr effect, all right? And this, describes how oxygenation of hemoglobin influences the binding and transport of carbon dioxide in the blood. Deoxygenated blood has a high carbon dioxide affinity. So this allows the hemoglobin to bind more to carbon dioxide and facilitating carbon dioxide transport from tissues back to the lungs. Conversely, oxygenated blood hemoglobin has lesser affinity, all right, for carbon dioxide. So what happens is that when hemoglobin becomes oxygenated, all right, its affinity for carbon dioxide decreases. Or as a result, oxygenated blood releases carbon dioxide, promoting exhalation of carbon dioxide in the lungs. And this, by any way, also encourages the release of hydrogen ions, and which combines with bicarbonate will form your carbonic acid, which rapidly dissociates into water and carbon dioxide for exhalation. So the Hardin effect is almost like opposite of your Bohr effect. The other factor that influences oxygen transport and your oxygen dissociation curve is the 2,3-diphosphoglycerate levels. All right, 2,3-DPG, as we know, is a product of glycolysis. All right, and it affects how hemoglobin releases oxygen to the tissues. So functions of 2,3-DPG, all right, it reduces high levels of D2,3-DPG, reduces affinity for oxygen, so it leads to unloading of oxygen to the tissues, all right? By helping hemoglobin release oxygen, the 2,3-DPG allows the body to adapt, okay, to conditions where there's increased oxygen demand by the tissues, such as during exercise at high altitudes and also in the state of hypoxia. So a high level of 2,3-DPG causes a rightward shift of your oxygen dissociation curve and leads to unloading of oxygen to the tissues. All right, so oxygen delivery, also known as oxygen flows, is the amount of oxygen that is delivered to the tissues per minute. All right, and there are certain factors that affect oxygen delivery. Number one is cardiac output. All right, during exercise, fever, or hypothyroid state, there's increase in cardiac output. All right, and because of increase in cardiac output, the amount of oxygen that is being transported, all right, to the tissues also increases. Conversely, when there is a heart failure or shock state, there's reduced cardiac output. I mean, that means there's reduction in oxygen delivery to the tissues. Hemoglobin concentration, we're going to look at some of these things when we come to talking about the causes of hypoxia as we go on. But know that anemia, all right, with reduced level of hemoglobin concentration will mean that there's reduced amount of oxygen that can be carried by the blood. All right, this will invariably lead to a reduction in oxygen delivery to the tissues. Polycythemia, on the other hand, with increase in hemoglobin concentration, will also lead to increased oxygen delivery, but this can lead to what we call stagnant hypoxia, because there's increased blood viscosity and leading to impaired flow. And conversely, this can give you what we know as stagnant hypoxia. The oxygen saturation, all right, also, if we look at the calculation or the formula of oxygen delivery, the lesser the amount of oxygen that binds to hemoglobin, the lesser the amount of oxygen that is being delivered. The same thing goes for the PaO2. All right, when you have reduced amount of oxygen that is dissolved in plasma, that invariably leads to a reduction in PaO2 and reduction in oxygen that is being delivered. The reason why I emphasize on oxygen delivery is the impact of oxygen delivery in clinical illness. All right, in critically ill patients, it's important that we monitor the oxygen that is being delivered to tissues. And there are interventions, therapeutic interventions that we usually employ in the ICU to improve oxygen delivery to the tissues. Number one is to augment your cardiac output, all right, by your inotropes and your vasopressors. All right, blood transfusion, all right, to raise hemoglobin concentration above a critical point also helps to improve oxygen delivery. And we also try to increase your oxygen saturation by giving oxygen therapy. All right, mechanical ventilation reduces oxygen demand and also maintains oxygen delivery to the tissues. All right, these are determinants of oxygen consumption, all right, and the metabolic demand, oxygen extraction ratio, all right, this is oxygen that is delivered to the tissue divided by the oxygen that is consumed. Normally, only about a quarter of oxygen that is delivered to the tissue is consumed, so we have an excess of about 75% that is not used, and this excess is what we use during increased metabolic demand. Okay, how well a tissue is perfused determines the amount of oxygen that is delivered and will be consumed by the tissues. Okay, I'm rushing now because there's so much to talk about. Now let's look at the laws that govern oxygen transport. There are 4 laws. I mentioned before the Dalton's law of partial pressure. All right, this is what determines the oxygen concentration gradients during the oxygen cascade we mentioned before. So remember that Darton's law states that in a mixture of gases, the total pressure exerted by the mixture of gases is equal to the sum of the individual pressures exerted by each of the gases. And these individual pressures are known as partial pressures of each of the gas. So in the context of oxygen transport, the total atmospheric pressure can be divided into the different pressures that each of the constituents of air, has, like oxygen, carbon dioxide, and nitrogen. And I showed that before. So the amount of oxygen that is available for transport, therefore, is influenced by its partial pressure. So when you have an increase in partial pressure of oxygen, the amount of oxygen that is being transported to the tissues will invariably increase. So the second law that governs oxygen transport is what we know as the Henry's law. I mentioned that before when we were talking about oxygen dissolved in plasma. All right, it states that the amount of gas that dissolves in liquid is directly proportional to the partial pressure of that gas. So the higher the partial pressure of oxygen, the higher the amount of oxygen that dissolved in plasma or in blood. The fixed law of diffusion, we mentioned this, all right? So the rate of diffusion of a gas, especially if you're looking at the alveolar membrane, all right? The rate of diffusion of a gas is proportional to the surface area, that is the alveolar membrane, and the difference in partial pressure across the membrane, all right? And inversely proportional to the thickness of the membrane. So in the lungs, oxygen diffuses from the alveoli, where the partial pressure is higher, into the pulmonary capillaries, where the partial pressure is lower. Now, what determines eventually is the thickness of the alveolar membrane. In some instances, when you have fibrosis and when you have all those thickened, or when you have filled alveoli, the alveolar membrane becomes thickened, and the diffusion of oxygen from the pulmonary circulation, all right, from the alveoli into the pulmonary circulation becomes impaired. The Bois effect, I mentioned this before so that we don't, yes. So let's go to oxygen therapy. I hope I'm not too fast. Oxygen therapy. Under normal circumstances, just about 21% of oxygen in the air is enough. But during critical illnesses, either because of sepsis or because of cardiac issues, this 21% oxygen is not enough. So we now, even during anesthesia and surgery where oxygen delivery to tissues may be impaired, we need additional oxygen, all right? And the aim of oxygen therapy is to restore the oxygen tension, that EPO2, to as near normal as possible. All right, so we look at hypoxia because when we're talking about oxygen therapy, we need to talk about hypoxia. And for the sake of academic purpose, we must remind ourselves the difference between hypoxia and hypoxemia. And a lot of times we use them interchangeably, but it is important for us to differentiate between the two. All right, hypoxia has to do with oxygen tension, the pressure of oxygen. When it's below a certain physiological level, at the tissue level, we have hypoxia. All right. Why? When there's a low oxygen tension in blood, all right, that's when we know that we call it hypoxemia. And hypoxia can be divided into four. All right. I use the mnemonic CASH. All right. So C represents cytotoxic hypoxia. A represents anemic hypoxia. S represents short hypoxia or stagnant hypoxia. And H represents hypoxic hypoxia or hypoxia secondary to hypoventilation. So when you're thinking about hypoxia, you want to talk about CASH. Like I tell my students and younger doctors, all right, when your patient is hypoxic, the patient needs CASH. All right, so think about cytotoxic hypoxia, and a lot of times this is due to cellular poisoning. for instance, cyanide poisoning. And the reason why it is important for us to differentiate the type of hypoxia is because it will determine the kind of therapy that you give to this patient. Now, ordinary oxygen therapy will not help in terms of cytotoxic hypoxia. You will need something like hyperbaric oxygen. All right. So exposure to cyanide, for instance, impairs cellular oxygen utilization. All right. And this prevents tissues from consuming the oxygen that is delivered to them. Here, oxygen delivery is normal. The problem is oxygen utilization. All right. Common causes of cytotoxic hypoxia include industrial exposure, miners and chemical manufacturing companies. Smoke inhalation during fires can also lead to carbon monoxide poisoning, which can lead to cytotoxic hypoxia. Anemic hypoxia is common, especially in our patients in ICU, maybe due to the primary illness or due to our frequent phlebotomies. All right. So there's a reduction in oxygen carrying capacity. And here, you want to increase your oxygen carrying capacity by transfusing this patient. And sometimes it may not just be a reduction in hemoglobin concentration. It may just be the presence of abnormal hemoglobin, okay, that is competing with the oxygen that is available. So common causes of anemic hypoxia in ICU or in critical setting includes hemorrhage from trauma or GI bleeding, hemolytic anemia from sickle cell disease, or you can have aplastic anemia. This will cause hypoxia because the amount of hemoglobin present in blood to transport oxygen is reduced. Then we have the shunt, all right? For instance, we have the intracardiac and pulmonary shunts, all right? We know the shunt refers to that portion of blood that bypasses the lungs, all right? And goes straight into the right side of the heart, all right, without being oxygenated. So conditions like, okay, please, if you're joining, can you mute yourself? Okay, I'm just, all right, so intracardiac shunts like congenital heart disease, such as atrial ventricular septal defects, pulmonary shunts, this will actually lead to what we know as VQ mismatch, especially pneumonia and ARDS. The last one, or the H, is the hypoxic hypoxia, all right? And this is when you deliver a gas mixture that is low in oxygen, all right? So it also may, those days when we're using what we, nitrous oxide, that's what we call diffusion hypoxia, all right? Those days, I remember, after you finish with your your anesthesia, you want to give 100% oxygen, all right, for about 5 minutes after you have turned off your nitrous oxide to avoid or to prevent what we know as diffusional hypoxia. All right, so this kind of hypoxia is known as hypoxic. It happens in high altitudes where your atmospheric pressure is lower. All right, invariably your partial pressure of oxygen will be lower. Inadequate oxygen supply. All right, you know, some ventilators, you know, electrically powered, all right, while some are flow powered. For those who are electrically powered, if the source of oxygen is not connected and you're ventilating your patient, even in theater, you're going to ventilate your patient with hypoxic gas mixture, and what you have is hypoxic hypoxia. All right, hypoventilation can actually also lead to hypoxia, and this can be due to different causes. CNS depression may be due to drug overdose or brain injury, neuromuscular disorders, your GBS or myasthenia gravis, kyphoscoliosis. All these lead to impaired hypoventilation, and this would lead to hypoxia also. I mentioned this stagnant hypoxia when there is reduced, localized, or generalized reduction in tissue blood flow. In polycythemia Rebreather, when you have increased blood viscosity, you can have hypoxia because the amount of oxygen that is being delivered to tissue is reduced. All right, so when we're talking about hypoxia, it's important for us to objectively measure the hypoxia we're having and to differentiate between intrapulmonary and extrapulmonary causes of hypoxia. And one of the ways to differentiate that is the measurement of your AA gradient. All right, the AA gradient talks about the difference between the partial pressure of oxygen in the alveoli and the partial pressure of oxygen in arterial blood. All right. So increased AA gradient, all right, suggests an intrapulmonary cause, all right, which could be due to shunt, all right, diffusion limitation or vacuum mismatch. When you have a normal AA gradient, this suggests an extrapulmonary cause of hypoxemia or hypoxia, which could either be due to hypoventilation or supply of hypoxic gas mixture. It's important for us to be able to calculate this. The normal AA gradient is between 5 to 15. And if you're going to use formula, you get H over 4 plus 4. So you get your PaO to the arterial partial pressure of oxygen from your ABG machine, but you need to calculate the partial pressure of oxygen in the alveoli. And this is what the importance of our alveolar gas equation comes to play. And we're going to see that in the next slide. Okay, so as I've said this before, normal AA gradient less than 15, with the cause of hypoxia, there will be hypoventilation, hypoxic air. All right, why? If it's more than 15 or more than exaggerated for that patient, you're going to be thinking about other things, the intrapulmonary causes like your vacuum mismatch, shunting, or diffusion impairment. Now, let's look at an example. A 40-year-old male patient breathing air at sea level, all right, atmospheric pressure of 760 millimeters of mercury and FiO2 of 21 because he's breathing atmospheric air, and has this blood gas. PaO2 is 60 millimeters of mercury, PaCO2 is 40, and the question is, what are the differentials? Definitely, this patient has some hypoxia here, all right? So what kind of hypoxia does this patient have? Determining the kind of hypoxia will also help you to know the kind of therapy you're going to institute for this patient. So the first thing, we have the age of the patient. If you're going to use our formula, age over 4 plus 4, the normal AA gradient for this patient will be 14. 40 over 4, that's 10, 10 plus 4, that will be 14. This is what is expected, all right? And if the AA gradient is this, and we're still having PaO2 of 60, we're going to be looking at hypoventilation or delivery of hypoxic gas mixture. All this patient is at high altitude, but don't forget that it's at sea level. So we know that the AA gradient should not be more than 14 for this patient. Then we calculate the partial pressure of oxygen in the alveoli, and you look at it, FiO2, which is 0.21, multiplied by the partial pressure, atmospheric, pressure, minus the water vapor, which is 47, all right, minus the PaCO2, which is 40, divided by the respiratory gradient at rest, which is 0.8. And your PaO2 here, you give you 99.73 millimeters of mercury. So if we calculate the AA gradient, that would be 99.73 minus 60, which is 39.73. So this AA gradient is elevated above the 14 that we expect for this patient at 40 years old. So what does this tell us? The problem here is that of oxygen transfer, either a vacuum mismatch or a shunt or diffusion impairment. And this is the relevance of calculating AA gradients for our patients. Or the second one to use is what we know as the oxygenation index. all right? And this is very more particularly useful for our ventilated patient. What it's telling us is that how much of pressure is needed, all right, to ventilate this patient to a normal PaO2, all right? So oxygen index is FiO2 multiplied by the mean airway pressure divided by the PaO2 multiplied by 100. All right. So the interpretation is this: if you have oxygenation index less than 5, you have normal oxygenation for this patient. But any oxygenation index greater than 25 represents severe respiratory failure. All right. But definitely any oxygenation index above 40 will require extracorporeal membrane oxygenation. All right. And this is also a feature of severe ARDS. So these two important parameters are useful in monitoring oxygenation for your patient, especially when you are instituting oxygen therapy. All right, so what are the indications for oxygen therapy? Yes, cash here, all right? Don't forget, I said the types of hypoxia can be cash. This one indication for oxygen therapy is also cash. So carbon monoxide poisoning, all right, that is the C. The other C is cardiopulmonary failure or patients with cardiac disease like ischemic heart disease. All right, A is anemia. When the patient is anemic, you want to increase your PaO2 while you're also trying to transfuse the patient. Shock, patient who is hypotensive, all right, and you know that will cause reduction in cardiac output. Sepsis, increase oxygen consumption, all right, and you will need to deliver more oxygen by oxygen therapy. Shivering, increased metabolic demand, all right, and then when you have hypoxia or hypoxemia resulting from hypoventilation or any form of hypoxia, maybe from breathing at high altitude. So these are basically the common indications for oxygen therapy. So there are different sources of oxygen therapy. We had a tutorial on anesthetic machine. So we have mentioned oxygen cylinders. All right, these are bulky. All right, most of the times they are used in the hospital setting. We have oxygen concentrators, which can be used at home, and sometimes it's being used in recovery rooms or PACO in some hospitals. And we remember how oxygen concentrator works. Make use of ambient air, all right, and zeolite granules are used to selectively absorb nitrogen from the compressed air, all right, and the oxygen is delivered to the patient. Then we have the fixed performance devices, also known as high flow oxygen devices. All right, the important thing here is that fixed performance devices, as the name suggests, delivers known concentrations of oxygen to the patient. The advantage is that it's economical, all right, and does not depend on the patient's inspiratory effort, all right. So the gas flow is sufficient to meet the patient's peak inspiratory and minute ventilatory requirement. All right. So, like I said, the fractional inspired oxygen that the patient takes is independent of the patient ventilatory pattern. Examples of fixed performance devices are your bench circuit oxygen tents of wood. We're going to see some of them. Venturi mask, not venture, Venturi mask. These are color coded with specific FiO2. We will see as we go on. Variable performance devices, also known as low flow oxygen devices. Here, the concentration, the FiO2 of oxygen that is delivered to the patient depends on the patient's ventilatory pattern. If the patient is hyperventilating, he has more FiO2 being delivered. All right, but if the patient is hypoventilated, you have reduced FiO2. Examples of variable performance devices include your nasal cannula, all right, no rebreathing mask, your partial rebreathing mask, and all that, or your simple face mask. These are variable performance devices, also known as your low flow system. Now, NASA cannula, this is a very common oxygen delivery device that we normally use. All right, it's a plastic disposable device that has two pins, two tips or prongs. All right, and is inserted into the vestibule of the nostrils. All right, it's able to provide up to 24 to 40% FiO2 of oxygen, and at 1 to 6 liters per minute. The advantage here is that it's easy to use, it's well tolerated by most patients. Patients can eat, drink, and talk, and also may be used in patients with COPD that require long-time oxygen therapy. All right, don't forget that they cause pressure sores around the ear and nostrils, especially for prolonged use. It also may cause dry, irritating nasal mucosa, but know that it's unable to achieve high concentration of oxygen in patients who require them. And most of the time, oxygen gets wasted and may not be good for mouth breathers. So because it's put on the noses for mouth breathers, it won't work. Then we have the high flow nasal cannula, all right? And the picture is by the right side. I don't know how many of us have used this before, all right? The important thing here is that it has a device that heats and humidifies the oxygen, all right? And it's able to deliver, high flow rate of oxygen, and that's why we call it high flow nasal cannula. It can deliver up to 60 liters per minute, and the FiO2 can vary from 21 to 100%. Advantages is that it delivers high flow oxygen with adjustable FiO2. You can adjust the FiO2. It provides a mechanism for PEEP, all right? And this helps to, improve oxygenation by opening up the alveoli at the end of expiration. It's comfortable and well tolerated, and it's useful for prolonged use. Another advantage here is that it's also useful during difficult airway, difficult laryngoscopy and intubation, because it ensures oxygenation even when you're unable to secure the airway. Disadvantages includes the need for specialized system. This device, all right, and may not be suitable for severe respiratory distress or failure. It's actually a temporary measure, especially during difficult airway or can't intubate, can't ventilate scenario. You ensure that you are at least able to deliver oxygen to the patient. All right, so the simple face mask you can see here, all right, is a variable performance device, delivers up to between 55 to 60% of oxygen at 6 to 10 liters per minute. Usually used for a short period of time, less than 12 hours, for you to get its maximum benefit. Then we have the partial rebreather face mask, all right? It has a reservoir bag which gets inflated during inspiration, can deliver up to about of 80%. Flow rate should at least be kept at 6 liters. Any flow rate less than 6 liters per minute, this partial rebreather face mask will not work, will not be efficient, because you need this amount of oxygen flow rate to be able to prevent rebreathing. You don't want the patient to have to rebreathe large amounts of carbon dioxide. All right. Advantage here is that the patient can breathe in room air through the openings. You can see the openings on the right side of the screen. Disadvantage is that it requires a tight seal, and for patients who are claustrophobic, it may not be comfortable for them. Now we have the non-rebreather. The difference between the partial rebreather and the non-rebreather is this two-way valve, all right, which prevents conservation of expired air. So this patient cannot breathe carbon dioxide. So that's why I call it a non-rebreather. Advantage is that it can give you high FiO2, all right, between 95 to 100% of oxygen, and it can give oxygen at the flow rate of almost at 15 liters per minute. Okay, disadvantage is that buildup of carbon dioxide, feeling of suffocation, because this patient cannot breathe it, all right, and it's very uncomfortable and expensive. The Venturi mask is an example of a fixed performance oxygen delivery device, all right? And it can deliver a high flow of oxygen from 40 to 50%. And if you remember the Venturi, all right, it works on the principle of Venturi, where air is entrained through a side arm, all right? It's an area of low. If you look at the oxygen passes there, and there's entrainment of air. So this kind of increases the flow rate of gas that is being delivered to the patient. All right. One of the advantages, in fact, the most significant advantage of Venturi face mask is that it provides the most precise oxygen concentration, FiO2, to the patient, and it gives room for humidification. All right. Now, let's look at it. They are color coded. That's another very important thing about Venturi mask. Each color has its own, FiO2 that has been delivered. And it's very important, especially when you are winning your patient from ventilator and when your patient from oxygen therapy. So remember the different color codes. Blue will give you a FiO2 of 24% at 2 liters per minute. White will give you 28% at 4 liters. And orange, 31% at 6 liters per minute. Yellow, 35%, and all that. I we used to remember that during those days with this mnemonic, beware of young root girls. All right. And I know the ladies also came up with their own and said, beware of young rich guys, whichever one you want, or just remember B stands for blue, W stands for white, O stands for orange, Y stands for yellow, R stands for red and green. So when we start winning patient from oxygen therapy, from ventilator, we start with the green, all right? And we monitor the SpO2, all right? At green, it's giving us FiO2 of 60. And the next day, patient, you can go to red, you are given reduced FiO2, and by the time your patient is comfortable with good oxygenation index and SpO2, with a blue Venturi mask, Venturi cone rather, Venturi cone, your patient will do well on room air. And this is the advantage of using the Venturi face mask. The T-piece, this is the T-piece, all right, is also an example of this performance oxygen device, all right. It gives you accurate and precise oxygen concentration. A lot of times we use them over as trying to test for rapid shallow breathing index as we're trying to win our patient off ventilator. All right, it's actually attached to the end of an ETT when you're winning your patient from ventilator. This is very important and very good as a winning technique. Oxygen tent is an example of fixed performance device. All right, a clear plastic shield that encloses the patient, usually a child. You can see that those of us who have worked in NICU or special care baby unit, all right, would have this. But the disadvantage is that it limits access to the patient and you can't use it during an emergency situation. All right, I like asking this question, especially for my undergraduate students. All right, I put a table and I ask them to fill it. All right, nasal cannula. All right, how much of flow, how much of FiO2, what is the maximum flow rate you can achieve? And just familiarize yourself with this because this is good exam question. Excuse me. Now, so we've talked about oxygen therapy. Oxygen is like a drug, so it has its own complications. And excuse me, those of you who have worked with me, you know that I always like asking this question, what are the complications of oxygen therapy? And it is the complication of oxygen therapy that makes us not to give 100% of oxygen for too long for a patient. When you're initiating mechanical ventilation, you may start with FiO2 of 1, but you want to rapidly reduce your FiO2, all right, so that you avoid complication. And another thing I tell people is that when a patient is desaturating, the first thing is not to increase FiO2 back to 100, because the longer the patient stays on high FiO2, of oxygen, the more you are exposing them to the risk of oxygen toxicity or complications of oxygen therapy. So farmland, remember farmland, fire. But I tell them, don't start with fire. All right. Know that oxygen is a highly combustible gas. It can cause fire if it comes in contact with flame, all right, or any electrical equipment. Absorption at electrolysis, all right, because large volume of oxygen will replace high concentration of oxygen will replace high volume of nitrogen, and this will, the oxygen is highly soluble and diffuses into the alveolar capillary membrane, and you have little or no oxygen left in the alveoli, so they collapse. So you have absorption at electrolysis because the oxygen that you're given has replaced nitrogen in the alveoli, and this same oxygen is rapidly absorbed into the pulmonary circulation, so you have collapse of your distal alveoli. All right, in neonate and premature patients, high flow of oxygen for a long time can lead to blindness due to retinal vasoconstriction. All right, and this is what known as retrolental hypoplasia in neonates. High flow of oxygen for a long time can cause myocardial depression, all right, due to reduced myocardial contractility, and this will lead to reduced cardiac output and can lead to cardiovascular compromise. Dr. Lawrence Smith had noted some years ago that increased PaO2 of oxygen for a long period of time can cause reversible lung injury. All right. So pulmonary toxic effect of oxygen arises after prolonged of oxygen above half atmospheric pressure. All right. So the longer the patient is exposed to oxygen, the more the risk of lung injury or pulmonary toxicity. All right. Anemia. All right. Free radicals of oxygen can cause a reduction in the amount of red blood cell that is produced by the bone marrow. All right. A lot of times, this is usually associated with hyperbaric oxygen therapy. Then we have CNS toxicity. All right. Remember tension. What we know, the CNS toxicity or neurological, we also call it Pauper's syndrome. All right. And this can manifest as tension, twitching of the muscles, ear ringing or tinnitus, nausea and vomiting, seizures, all right, irritability, patient can become obtunded, all right, and you can have all this, the important thing is the FiO2 and the duration of therapy can lead to this CNS toxicity. Carbon dioxide narcosis, especially in patients with COPD, all right? So oxygen-induced carbon dioxide narcosis can lead to loss of consciousness or coma. And high flow of oxygen for a long period of time can lead to suppression of your erythropoietin release from the kidneys, and that can lead to depressed homeopoiesis. And also that can account for the anemia that we mentioned before. Now, this table just shows oxygen tolerance curves. All right. Now, the PaO2 versus time graph. Okay. At high PaO2 for a short period of time will not cause much harm. But by the time you are getting to 10 to 15 hours of high FiO2, look at at 2 atmospheric pressure. All right. By the time you're getting to this point, you're crossing the limit of the oxygen therapy, and you're going to have CNS and lung toxicity. So this is the graph that we must always remember, all right? So as the duration of oxygen therapy increases, your PaO2 must also decrease. That's your FiO2. Your FiO2 must come down as you prolong your oxygen therapy, all right? And that is why the use of Venturi mask helps us, all right, to reduce the FiO2 we're given if the patient requires prolonged oxygen therapy. Okay, so this is pulmonary toxicity, Lawrence Smith syndrome, like I mentioned. So this results from ventilatory failure. All right. When you inhale high FiO2 for a long period of time, for FiO2 of greater than 50% for over 24, 48 hours, can cause pathological changes in the lungs. So please be careful in ICU. Don't give oxygen of more than FiO2 of 0.5 for more than 24 hours. All right, you're going to have problems with the patient's lungs. And the causative agents are the oxygen-free radicals. All right, so your patient can hypoventilate, patient become ventilator dependent. The patient can also have difficulty with breathing and all of this chest pain. So limit this administration of oxygen to less than 0.4 or less than 0.5 if you're going to give oxygen for more than 24 hours. All right, so how much of oxygen is saved? 100% of oxygen, not more than 12 hours, please. Okay, don't give oxygen FiO2 of 100% more than 12 hours. All right, don't give more than 80% more than 24 hours. Anything above 50% for 24, 48 hours is going to be problematic. The goal of oxygen therapy be to use the lowest possible FiO2 compatible with adequate tissue oxygenation. And that's why all those oxygen index parameters I mentioned before becomes critical. Oh, time is gone. I can't talk about hyperbaric oxygen therapy. I'm sure by the time you get to the slides, you should have them. All right. So let me stop here. Ladies and gentlemen, let me open for questions and contributions.